Am I audible? Can you just type in the message box? So, okay, we will do first the varicose vein because yesterday one student, she made a query about the varicose vein with varicose ulcer, okay, and Madura food. Okay, just wait for. So only 9 people are there. Let's move. Has been wait. Okay. हो गया था. This has been done. So कितना भी स्टूडेंट्स है अभी? सो 9 स्टूडेंट. शैल वी स्टार्ट द क्लास या थोड़ा वेट करते हैं 1 मिनट? थोरैक्स एंड लंग्स या वेनस डिसऑर्डर्स. ठीक है, लेट्स स्टार्ट. Okay, now if you see this diagram, let me close this one. Yeah. So if you see this one, where this is a normal, I am audible, right?
Yes, ma'am.
Okay, chalo then. ठीक है. So अगर if you're seeing this diagram, so this is a normal blood vessels, okay, the veins, okay. In varicose vein, what happened? There is in the varicose vein, there is the veins become dilated, tortuous, and they become elongated. If you see in this diagram, there is an backflow of the blood, okay, because artery is like coming to the like artery is coming and blood is, and via the veins the blood is going towards the heart, okay. So there is an upward flow of the blood. But here is what happened. This valve has become incompetent, okay. It has ability to contract, okay, to just to prevent the black flow of the blood. If it has become incompetent, so what happened? There is a backflow of the blood, okay. And if there is a backflow of the blood, so the veins become excessive, the blood become excessive, venous blood, and becomes dilated and tortuous. So this is actually the you can say the definition of the varicose vein. Okay, so if you see this normal blood moves up, valve close, and there is a no backflow of the blood. You can take the picture of this slide help for you to understand this. And here if you see this blood goes up, comes back, pooling of the blood and the veins dilate. Okay, so this is basically the basic mechanism for the varicose vein. Okay, so now in the next slide, what are the common causes or the risk factor for the varicose vein? So one is prolonged standings. A person who have worked for a prolonged standing, this is the one. No, pregnancy, obesity, old age, family history, okay, and those occupations which requires a long standings, okay, such as in traffic police and all these things. Okay, so these are the common or the risk factor for the varicose vein. Okay, remember most of the varicose veins is developed into the greater saphenous vein and also in the lesser saphenous vein. So greater saphenous vein and the lesser saphenous vein. In the lesser saphenous vein, the tributaries are also dilated. Okay, so usual distribution of the varicose vein is below the knee, okay, and its branches of the greater saphenous vein, okay. If it is there, the branches of the greater saphenous vein, and if it is in back of the calf muscles, that means your lesser saphenous vein is affected. So if there is, and suppose a patient comes to your in a clinic, okay, and he will show you some dilated tortuous vein, okay. So if the varicosities in the thigh, okay, so if it is in the thigh, that means a greater or the long saphenous vein is affected, okay. And if it is in the back of the leg, if the varicosities in the varicosities, if I'm going too fast, tell me to slow down my pace, okay. Varicosities on the back of the leg, ठीक है. So this is very important. If it is in the thigh, it is in the greater saphenous vein become incompetent. If it is in the back of the calf muscles, then the lower saphenous vein, and that is your short saphenous vein, is get affected. Okay. Now, there are basically two types of vein. One is your primary varicose vein, and other is your secondary varicose vein. Okay, so now the varicose vein is divided into the two types. One is primary one, another is your secondary one. So in the primary one, here is the varicose veins due to the primary valve weakness without any affection of the deep vein. So basically superficial veins get affected here, and these are the most common among the primary and the secondary. The most common is the primary varicose vein. Okay. So what you will see, it is due to the congenital, or if there is an hereditary weakness of the veins, there is no obstruction in the deep vein. So here the deep vein is not affected. Okay. These are the long history. They are usually they are bilateral. Great saphenous veins are commonly involved. Deep veins are the normal. Okay. So these are the primary. From the primary and the secondary, primary is most common. Now, if you go with the secondary, it affects the deep venous. So deep vein is usually affected. So causes will be the deep vein thrombosis. There will be some pelvic tumors, pregnancy related some compression, and also one of the reason is if there is a trauma. Okay, if there is a trauma, or like your AV fistula. Okay. So secondary veins, these are the less common. They are less common, and the causes will be this, and usually they affect the deep veins. Okay. So here the deep vein block, the overload and dilatation, they're often unilateral. दोनों का what do you say, the difference आप याद रखना. They can ask you in the MCQ examination among this, which among this the option is correct. Okay, remember secondary varicose vein are often unilateral and they are usually bilateral. ठीक है. So secondary है often unilateral, and they are associated with they are more prone to develop venous ulcers and the skin changes rather than that of the primary varicose vein. Okay. So these are the two types. One is primary one, and which is more common, and other is your secondary one, which is less common. Okay. Now, what are the clinical features? Visible, the blue twisted veins. There is an heaviness of the leg, aching pain in the calf muscles or in the leg, which is worse at the end of the day. Okay. So dull aching pain in the veins at the end of the day after prolonged standing. Ankle swelling, ankle edema is there, night cramps, and if the ulceration is going to develop, that previously you will see itching and the pigmentation. So some of the questions you can ask whenever you're sitting in a clinic and the patient comes to you, and if you see that there is a dilated vein, see there is another vein which is known as spider veins, which I come into the later. So varicose veins are usually dilated, they are tortuous, they might be come with you with the clinical feature of बहुत दर्द होता है, heaviness, and या तो भारी लगता है. These are the two common symptoms. Okay, usually pain in the legs or the heaviness in the leg, or pain in the legs if I stand or if I work for a prolonged period of the time. Usually this pain is usually relieved if the person elevate his feet. Okay, elevating the feet, usually the pain get relieved after the elevating the feet. Okay. So okay, so these are the some of the clinical feature. How will you diagnose this case? With the help of the investigation will be your duplex ultrasound. Investigation will be the duplex ultrasound. Okay. So these are the some of the clinical feature of your varicose vein. There is an Besgard regimen. Okay, so what is Besgard regimen? They can ask you, what is Besgard regimen? So Besgard regimen means it is limb elevation. This is basically in the treatment part. You will have to tell the patient, okay, time to time in a 24 hours in a day, अगर दिन में कभी भी लेट जाइए and elevate your limbs. Okay, so limb elevation plus stocking. He or she should wear the stocking. Okay, so there is a compression stocking. It is easily available in the medicine shops, medical shops, and plus the massage of the varicose ulcer. Okay, so massage for the varicose ulcer or the varicose veins. Okay, so these are the by Besgard regimen. Okay, if the sometimes what happen the if there isn't too much swelling in the varicose vein, it get burst and the bleeding also start. Okay, which is in a rare form indication. That means if there is if the veins is swelling is too much, the veins become dilated, it becomes thin, and sometimes from the veins the blood started to ooze out. Okay, so these are the another symptoms. No, what is the, if the question asks, what is the clinical test for the varicose vein? Okay. The clinical test for the varicose veins will be your Brody-Trildenberg test. Okay. Brody-Trildenberg test. So this is one of the clinical test. It is used, this test is positive. Okay, this test is positive. There is an incompetence spheno-femoral junctions, or if there is an incompetent perforated veins, to assess the site of the venous valvular impotence, especially in saphenofemoral junction or the perforated vein. So this is another questions. Okay, so they can ask you what is the Brody-Trildenberg test is used for. They are used for the to diagnose the incompetency of the valve, especially the perforator veins or the saphenofemoral veins. Now, how will you perform this test? You will have to tell the patient to lie in a supine position, okay, and tell him to raise the leg to empty the superficial veins, okay. Now, what you do, now suppose this is a, the, yeah. So what happened when you apply, you have to apply the tourniquet in the upper thigh, okay, just below the saphenofemoral junction, and or you have to pressure this junction, okay, this in the upper thigh just below the SF junction, you have to give some pressure, okay. Okay, and then tell the patient to stand after releasing the tourniquet, okay. After releasing the tourniquet, now observe the veins filling. Now, what happened if the veins fill rapidly only after the tourniquet release? You release the pressure from the SF junction, okay. What you will see that veins fills rapidly, okay. That means this is due to the SFG incompetence. Okay, so pressure on the SFG is released and veins started to fill quickly. Okay, this indicate your saphenofemoral junction incompetency. Okay, now what you will have to do? Now pressure on SFG is not released. Okay, so tourniquet is still on and you will tell the patient to stand. What you will see, the veins fill even with the tourniquet on. Okay, this is means your, it fills very much gradually, but still it fills. This is known as a perforated incompetency. It is positive. Okay, and no rapid filling even after the release. This means valve is competent. It is your normal. So basically इतना कुछ नहीं आता है. Just wanted to know the procedure. It can the only two questions they can ask है, what is the Brody-Trildenberg test is used for, and to assess the which femoral or which junctions, okay, or the which nerves. Then you have to say the sorry, which veins, or the perforator veins or the saphenofemoral junctions. So if they can ask you, what are the complications of the varicose vein surgery? Okay. What are the complications of the varicose vein surgery? Most common is the recurrence. We have in Homeopathy are very good medicines for the varicose vein surgery. Okay. One is your most common is the recurrence, and the other is your hematoma or the ecchymosis. So these are the most common complication. Okay, ecchymosis. Okay, so whenever if I see if I get anything, yeah. So this I just wanted to tell you. Yeah, this is about your venous ulcer. So this is all about your varicose vein. Wanted to tell you one thing regarding the therapeutics. So suppose if you get any patient of the varicose vein, whether it is like torture, whether it is highly dilated, whether it is just started means see it is like this. It is not a fully developed varicose vein. It's basically called as in spider veins. Okay, so this situation and this situation they can easily be treated. Even when there is an edema and the swelling, it takes a long period of the time, and especially this case, the spider vein, they are easily treatable. Okay. So during all these things, like in every cases, one of the main common remedy which I have seen mostly doctor use, these are the hemamalis. You can use the hemamalis mother on the applications. Even there is, suppose if there is a sudden bleeding from the veins, you can use the hemamalis mother as an applications, use as an gauge, or the Ferrum Phos 1x. It is difficult to find this potency. If you can find, just take it. Okay. So Ferrum Phos 1x and the hemamalis, just it's a tip. Okay. When there is a bleeding. Okay. So yeah, just move to the next part about the varicose ulcer. Okay. So ये हो गया varicose vein, the test, and then come to the varicose ulcer. Hmm. Hmm. So if you see the first is your there is a spider vein, then it varicose vein, then there is a swelling, then there is a skin changes, and then later part there is a venous ulcer. So 62 venous diseases is responsible for the 60 to 70% of the varicose ulcer. Okay, so varicose ulcer, so about 60 to 70% of the varicose ulcer is due to the venous diseases. Okay, so there is a various causes for the leg ulcer. Okay, for example, if there is there's various causes of the leg ulcer. If there is an arterial ischemic ulcer, okay, the peripheral arterial disease. Yesterday we studied the rheumatoid ulcers, rheumatoid arthritis, which resulting in rheumatoid ulcers. If there isn't some trauma, it can also result in ulcers. Okay, and some squamous cell carcinoma and the cell carcinoma also resulting in this type of this ulcers. So if they ask you the question, what is the most common site? Your answer will be the medial malleolus. Okay, medial malleolus. There is a valve incompetency. As a result, venous hypertension, veins get dilated, capillary leakage, okay, edema and tissue hypoxia, which resulting into the ulcer formation. So the ulcer will be shallow ulcer with sloping edges. The margins are very much irregular, okay, painless or mildly painful, and surrounding area of the skin there is an hyperpigmentation, eczematous varicose eczema. Okay, the clinical features of this eczema is also there, and the lipido uh, lipodermo dermatosclerosis. Okay, the affected area become thick, it become thick and also indurated. Okay, so lipidosclerosis means lipid, okay, so there is a thickening and also the induration. Okay, the scleros, the affected part become thickened, or there is an in fibrosed or the indurations. Okay, of the skin. So this is known, this three together, hyperpigmentation, varicose eczema, and the lipid dermatosclerosis. These are the surrounding area you will see in the varicose ulcer. Pigmentation is also there due to the deposition of the melanin or the hemosiderin. Pigmentation is due to the deposition of the melanin and the hemosiderin. Okay, majority in which side? In the medial malleolus. Okay. In this case, okay, now just wanted to tell you, if you see, this is in spider vein and this is in varicose vein. When you see there is a dilatation, okay, it's a tortuous, this is swelling is there. Okay, so how will you? So in spider veins, the size will be 1 millimeter, less than 1 millimeter, and varicose vein, the size will be more than 3 millimeter. Usually the dermis is affected, dermal layer, but it is only the subcutaneous. Spider vein symptoms are cosmetics and they are mostly painless. I have seen 2 to 3 cases which are painful. Okay, so though it is written in the book, it is painless. Okay, so maybe 95% of the cases are painless and 2 to 3% of the cases are painful. I have seen the spider veins, mostly they are painless, but 2 to 3 cases, the patient comes to me only with the pain. Okay, and one of the best medicine which I use, that is the pulsatilla. You can use the pulsatilla in any potency. Okay, okay, now other is your in here varicose vein. This is pain and the heaviness. Complication is none. They resulting in the ulcer and the eczema. So varicose veins are difficult to cure rather than from the spider veins. ठीक है, यहाँ पर valve incompetency नहीं रहती, यहाँ पर valve competency present रहती है. So suppose if the 2 person comes with you, one is in this stage and another in this stage, tell them that this will take time. The varicose veins will take time to heal. Okay. Okay, now come to the what is champagne bottle leg, usually seen in the varicose ulcer. It is basically your lipidermatosclerosis, usually seen in the lower third of the leg. If you see that, it becomes constricted and the calf remains broad, looks like a downward champagne bottle, inverted champagne bottle. Okay, so this is usually seen in the varicose ulcer. Okay, so skin become hard, thick, indurated, and the tender. So there is an ankle swelling is there, champagne bottle like seen is the leg is like a inverted champagne bottle. Okay, so investigation, how will you diagnose? It's only through the clinical features. ठीक है, और पूरा अगर no to confirm it or anything, investigation of the choice will be or a duplex ultrasound. ठीक है, if you can do, otherwise the clinical your clinical eye will only tell you that see this is a case of a varicose vein. ठीक है, so now come to the, so this is anything. तो हम लोग फिर दूसरे टॉपिक में जाएंगे. Okay, so if you miss any slide, do let me know in the chat box. Chalo. So let's move to the next part about your superficial thrombophlebitis. So superficial thrombophlebitis is inflammation of the superficial veins. So there is an inflammation of the superficial veins along with some small thrombus formation. So this is a definition. The cause will be, varicose vein, IV injection, usually most common cause, especially in the hospital. If you see the old people whose skin is very thin, okay, they have mostly, you will see this type of the superficial thrombophlebitis. That the most common causes agar repeated IV, if they're using repeated IV injections. Most commonly, if you're working in a hospital, okay, you will see in the geriatric wards. Okay, now trauma, infection, hypercoagulable state. The clinical feature will be painful, tender, red cord-like vein. If you touch, there is a slightly warmth, swelling of the along the vein, mild fever, overlining, skin erythema. Okay, see, whenever there is any type of the venous problem is there ना, go our venous remedies है. ठीक है, तो जितने सारे snake remedies है ना, they are the venous remedies है. ठीक है, उसको use करो. Plus अलग जो veins remedy है, one is your hemamelis, other is your pulsatilla. They act on the veins also. Okay, and the cardus marinus. Okay, so these are the remedies which usually affect on the veins, plus all the remedies which are in the snake kingdom. ठीक है? So lachesis हो गया, vipera हो गया, Crotalus horridus हो गया. These are all comes whenever this type of the cases you will see. Okay. So now come to the next part of so this is all about your superficial thrombophlebitis. Now come to the Madura foot. What is Madura foot? Okay. So if you see that, so Madura foot is in chronic granulomatous infections of the skin, subcutaneous tissues, bone. Okay, so these three together. Okay, skin, subcutaneous tissues, and the bone, which is characterized by the swelling, multiple sinuses, and the discharge of the grains. Okay, what are the causative organisms? There are basically two types. Okay, the fungal is mainly caused by the Madurilla myositis, which is most common. Actinomycetoma is in bacterial. Okay, click the slide. Okay, what are the clinical triad you will see? Okay, so here is the mode of infection will be the organism that can enter into the minor trauma, common in the barefoot farmers. Clinical trial will be the painless swelling, multiple sinuses, and the granular discharges, white granular discharges. Okay, the foot is most common. Type of the grain is black grain, which is fungal. White is mostly due to the actinomycetoma. Okay. Investigation, you can examination of the brain, grains, X-ray, the bone involvement from the grain. You can examine which bacteria is responsible for this, and then the culture and the biopsy. So this is all about your Madura food. ठीक है? चलो, किसी को कोई स्लाइड दिखाना है मुझे? अगर हाँ तो just type me in the chat box, and else I will move into the next chapter. Okay.
होता है
कौन सा?
ये मदुरा फूड
क्या करना है?
पेनलेस है, मतलब ये पेनलेस है.
Yes, mostly painless because already the bones get affected. Multiple discharge. If the nerves get affected, most commonly they are the painless. If you see some क्या बोलते हैं उसको, grains तो आता ही है, and sometimes you will see some small insects over there. क्या बोलते हैं उसको, याद नहीं आ रहा है something. ठीक है? Okay. Shall I move to the next part? Madura. Let me see, what is that organism called actually? And you will see mostly in the case of the farmers, if you practice in the rural areas, you will see this type of the cases. I've seen only one cases in my life, but chalo, or let's see in the next part. Okay. Yeah. तो मोस्टली पेनलेस ही होता है. अगर सपोज कोई बैक्टीरियल इन्फेक्शन हो गया, इन्फ्लेमेशन हो गया, देन यू विल फाइंड सम पेन. ओके, लेटर स्टेज में जब बोन इन्वॉल्वमेंट हो गए हैं, बहुत इन्फ्लेमेशन ज़्यादा हो गया है तो ही, अदरवाइज अर्ली स्टेज में वो नहीं होगा. ठीक है. एंड आफ्टर एकदम जब साइनस ट्रैक्ट हो जाता है, जब नर्व एकदम अफेक्टेड हो जाता है, अगेन इट बिकम पेनलेस. Okay, no? Yes, sir. Okay, this one. So now come to the spina bifida. Okay, so basically vertebral body anomalies. Okay, so they are divided into two types. vertebral body anomalies, they are divided into two types. One is your spina bifida, okay, spina bifida occulta, and other is your spina bifida aperta, okay, spina bifida aperta, ठीक है. तो यहाँ पर spina bifida occulta है, okay. Occult means something is hidden, okay. So something is hidden, skin may look is your normal. Here what happened? Usually some patient may have some there is no meninges, no vertebral bodies, or no spinal involvement is there. Okay, usually they are the asymptomatic. No visible sac is seen, often seen in the effect in the MRI, and usually affect the LF and the S1. So they can ask you this: in which vertebral body you mostly commonly see in the spina bifida. Sometimes the patient will come you only with the hairs or the some birthmark on the back or small dimple or pit, or there is an hemangioma, okay, or slight skin discoloration. So there is an incomplete closure of the vertebral arcage with protrusion of the meninges or the spinal cord, okay. So this is known as an spina bifida occulta. It does not require any treatment. It is most common form and it is the most mild form. Okay. So it is only the clinical feature. Sometimes nothing is seen and sometimes you will see some hair, the dimple or the birthmark. Okay. So remember it has no symptoms. It has no symptoms, no visible sac, most commonly in the LF and the S1, and the skin may looks normal, okay, which is one of the mild form. There is an even meninges of spinal cord को उतना भी protrusion होता नहीं है, very mild form, okay. Now, so if you see the difference between this, now spina bifida aperta, it is again, it has three types, but the most commonly is your meningocele and other is your myelomeningocele, okay, myelomeningocele, ठीक है. So इतना याद रखना, in occulta there is an incomplete arc. Meningocele is also, there is a defect in the vertebral body along with this meninges involvement is there. In myelomeninges there is a defect in the vertebral body with the meninges and the also there is a cord. Skin looks normal or there is slight dimple. It is looks often normal, and here the often sacs are present, okay. There is swelling is present. Neurological deficit is not here. It is present but rare in some cases and it is very much common. Okay, visibility, it is not visible, but yes, it is has visible sac. Protrusion is there. It is also has some protrusion. Okay, so it looks like this case in the meningocele. So it is, what is this? A neural tube defect where the meninges herniate throughout the vertebral defect. Okay, and it contains cerebrospinal fluid. Okay, so it contains the meninges and the CSF. दिस इज इम्पोर्टेंट, ये सब इम्पोर्टेंट पॉइंट है, ठीक है. इतना ही याद रखो, यू हैव नथिंग टू लुक आफ्टर द अदर बुक, और क्वेश्चंस आएंगे तो तुमको इजीली सॉल्व हो जाएगा इतने से ही. ओके, डज नॉट कंटेन द स्पाइनल कॉर्ड और द न्यूरल टिश्यूज, याद रखना. ओके, डज नॉट कंटेन द स्पाइनल कॉर्ड एंड द न्यूरल tissues. The spinal cord is usually normal and normal in position, okay, and neurological deficient is usually absent or the minimal. In clinical, you will see a cystic transilluminant swelling over the spine in the lower back, okay, usually in the midline over the lower or the sacral region. Size varies, depends upon the what amount of the second, kitna fluid rahega CSF. Size varies from the small to the large. Okay, so they are also the asymptomatic. Okay, usually treatment should be done if they are leaking the CSF or the thin, the skin covering is very thin, and you will see some CSF is also leaking. So this is about your meningocele. Most common, this one, okay. So how will you diagnose? In the antenatal, maternal serum AFP is increases. Ultrasound shows some cystic posterior marks. Okay, MRI spine to assess the neural structure. Okay, so this is the important points. What are the complications? Rupture of the sac, if there are infections, CSF leaf, associated anomalies are there, but it is less common than that of the myelomeningocele. Okay, so meningocele, meningitis plus CSF contains the spinal cord also, the myelomeningocele. Neural deficit is absent, it is severe, prognosis is good, myelo 1 is very poor, transillumination test is positive, it is negative, skin cover is usually intact, often thin or the absent. Okay, so these are the difference between the meningocele or the myelomeningocele. So in case the classical appearance, you will see a visible swelling. It is non-trans illuminate mass. याद रखना, ठीक है? जैसे ये क्या था? It is your trans illuminating swelling. So you have to remember the difference between these two. Okay? Non-trans illuminate mass covered by a thin membrane consists of spinal cord also. Okay? Most common location in the lumbosacral region. ठीक है? They have more chances to become ruptured or the ulcerated. Okay, mid lumbar region. So there is a paralysis of the lower extremities, absence of the deep tendon reflexes, okay, and lack of response to the touch. Usually is very rare. 1 by the 4,000 live birth. Okay, 1 into 4,000 live birth. Okay, and depending upon some, suppose if it is in the lower sacral region, now sometimes what happen, the clinical feature is also depends upon where the swelling is present. Now suppose if it is in the lower, if the meningomyocele is present in the lower sacral region, okay, in the lower sacral region, okay, so there will be the bladder or the bowel incontinence. Okay, so there is an bowel and the bladder incontinence. Okay, or also there is an anesthesia of the perianal area. Okay, if it is in the mid lumbar region, then the flaccid paralysis of the lower extremities. Okay, if it is in the thoracic region, which is very rare, so if the meningomycel affect the thoracic region, it is your rare chances. It causes your increasing neurological deficit. Okay, जितना higher होगा उतना न्यूरोलॉजिकल डेफिशिएंट ज्यादा इंक्रीज होता रहेगा. Okay, so there is an increase, there is an increase neurological deficit. ठीक है, सिर्फ इन दोनों का आप ये दिस इज वेरी इंपॉर्टेंट एक्चुअली, बाकी उतना इंपॉर्टेंट नहीं है. दिस इज एन इम्पॉर्टेंट, इसको याद रखना. मेनिंजस, CSF, न्यूरो डेफिसिट एब्सेंट, सीवियर, also severe where the it is located. Okay, prognosis is good and the poor. Now what do you mean by the Dandy Walker syndrome? Also classical triad क्या है, बस इतना ही याद रखो. ठीक है, Dandy Walker syndrome, it is a congenital brain malformation which is characterized by the cystic enlargement of the fourth ventricle. So if you see in this diagram, so this is your cerebellum. So here the cerebellum part is there. This is the fourth ventricle. Okay, so here the enlargement of the fourth ventricle. Okay, cyst formation is there, or basically there is an enlargement of the cystic enlargement of the fourth ventricle. Okay, and there is an cerebral vermis, that is hypoplasia or the agenesis of the cerebral vermis and the enlarged posterior fossa. Okay, So basically, most common posterior fossa malformation prevalence is 1:30,000 live birth. Okay. So this is very important. What happened? There is a cystic enlargement of the fourth ventricle, agenesis of the cerebral vermis, and the enlarged posterior fossa. Okay. Now, what are the clinical signs and symptoms? The reason most common symptom is your macrocephaly. This is the most common symptom. Okay. So 80% of the cases, you will see there is a macrocephaly, some and associated with your hydrocephalus. And 90% of the cases, the head is this Dandy-Walker syndrome malformation. It is associated with the hydrocephalus. So this is most common symptom. इसके साथ obviously if the brain development is delayed, so all the development become delayed, so poor coordination, developmental delay. Okay, seizure is there, but it's very much less common. If you see the head is very enlarged, even the occiput is very much prominent. Okay, so if it's there, the occiput is very prominent. Okay, look at this, the occiput is a prominent occiput. Thus, all the feature of hydrocephaly is also present, prominent occiput, and also trans-illumination test is a positive one. Okay.
मैम ये ट्रांस एलिमिनेशन टेस्ट क्यों करवाते हैं?
ये फ्लूइड है ना, करवाते जब तुमको वैसे इस फ्लूइड क्या, जब भी आप टॉर्च दोगे तो क्या होगा, वो फ्लूइड एक ग्लो करेगा. सो कोई भी जगह में हाइड्रोसिल में फ्लूइड होता है, तो किसी भी एनलार्जमेंट में फ्लूइड हो ना, पानी की तरह फ्लूइड होगा, तो वहां पर पॉजिटिव होगा. मत ही करो, जरूरत नहीं है, क्लिनिकल आई ही क्या है. अभी तुमको एमसीक्यू देगा in which cases this is positive, that is why I'm just telling you. Okay, trans illumination test is a positive. Chalo, now let's do the another part about your causes for the cerebrovascular accident. So it is divided into the two part. Okay, one is your ischemic and the other is your hemorrhage. Okay, so one is your ischemic and the other is a hemorrhage. Ischemic is 85% of the cases and the hemorrhage, okay, in the 15% of the cases. That means ischemic cerebrovascular accident is more common than that of the hemorrhage. ये question हो गया, ठीक है? Which is more common? Ischemic is more common. Okay. Now in ischemic maybe there is an embolic, okay, embolism or thrombotic formation of the thrombus. Okay. So इसमें भी embolism जो embolic है, it 75% cases and बाकी का 25% is thrombus है. In the hemorrhage, okay, there are various type of the hemorrhage. For example, parenchymal hemorrhage, okay, okay, parenchymal hemorrhage or the intracerebral hemorrhage, okay, subarachnoid hemorrhage, which is usually seen in 1 to 22% of the cases. Parenchymal hemorrhage is more common in the 10% of the cases. Epidural and the subdural, okay, they are less than 1. Okay, epidural hemorrhage and the subdural hemorrhage. Okay, so this is very important. इसमें से clinical symptoms ही आपके important है, वही क्वेश्चन पूछ सकते हैं, ठीक है. So cerebrovascular accident, ischemic and the hemorrhage. Ischemic is more common than that of the hemorrhagic one. Embolic and the thrombosis, among this embolic is more common, and among all this hemorrhage, the parenchymal hemorrhage is more common. Okay, now come to the intracerebral hemorrhage. Its other name is also parenchymal hemorrhage. Okay, इसका दूसरा नाम क्या है, parenchymal hemorrhage भी उसको बोलते हैं, ठीक है. If I'm going too fast, let me know. ठीक है. So what is this? Is the most common type of the intracranial hemorrhage among all the hemorrhage, and इसका most common cause क्या है? Hypertension. Important MCQ. What is the most common cause of the parenchymal hemorrhage? Hypertension. Okay, and basically there is a rupture of the small arteries. okay, small arteries, and mostly in the which part? In the putamen. Okay, so these are the basically in which part? This is the putamen region, in the putamen. Okay, most common site where? Most common site is the putamen. Okay, in the basal ganglia. Okay. So now come to the subarachnoid hemorrhage. It is a second most common of the intracranial hemorrhage. Second most common cause. First हो गया parenchymal. This is the second most common. इसका most common reason क्या होगा? Trauma. Okay. Or rupture of the berry aneurysm. Okay. Or there is a spontaneous rupture of berry aneurysm. Okay. So basically we know that the and also in the rupture of the berry most common site of the berry aneurysm is the circle of the Willis. Okay, anterior circulation of the circle of the Willis. Okay. So what are the common clinical features? Thunderclap headache, or the worst headache of the life. Along with this, there is a meningeal irritations. Okay, blood enters into the subarachnoid spaces, which causes neck stiffness, photophobia, burning sign. Okay, decreased level of consciousness. This is very important. Sudden severe headache or the thunderclap headache. Okay, there may be a past history of injury. Okay, the patient does not vomit it. Okay, he was unconscious for a few minutes and then he is okay. But after 1 month or after 15 to 20 days, he suffered from a severe type of the headache. He come with you a headache problem. Okay, so sudden severe headache. So either there is a history of the trauma नहीं हुआ, तो you can say there is some aneurysm which can burst out. Okay. So and also in the circle of the Willis, and that also in the anterior circulation. So in case of this, most common location of the berry aneurysm is your MCA, middle cerebral artery. Okay, so this artery, they have more chances to rupture. Okay, so this has more chances to rupture in the subarachnoid hemorrhage. Okay, and you will see blood in the syphilian fissures. The patient, whenever there is a rupture, okay, the patient either complain of the hemiparesis along with the aphasia. Okay, so aphasia, hemiparesis, if there is a rupture of the berry aneurysm, especially the middle cerebral artery. Okay, so this is all about your subarachnoid hemorrhage. Okay. Otherwise, unruptured aneurysm is asymptomatic. अगर aneurysm ruptured हुआ, then in only it is symptomatic. Otherwise, it is asymptomatic. ठीक है? Now come to the extradural hemorrhage or the extradural hematoma. Okay, so here that is your blood accumulate in between the space between the dura mater and the bone. Okay, so extradural hematoma means dura mater and bone if there is an accumulation of the blood. Okay, so most common site is here in the temporal bone. Remember, the most common site is the temporal bone. Okay, in the temporal bone. So trauma is the most common cause. There is a middle meningeal artery tear. Okay, it is most common, and middle meningeal vein is a less common. The most common clinical feature, you will see the lucid interval. Okay, so this is an important high yield questions. Okay, so I'm writing in star marks. Lucid interval, that is initial unconsciousness, temporary recovery, and rapid deterioration. Okay, so lucid interval is usually seen in the extradural hemorrhage. बहुत बार पूछता है, in which hemorrhage you will see the lucid interval. Okay, so initial injury followed by the lucid interval, which is occurred in 1/3 of the cases. Okay, if you see in the CT scan, it is a gold standard diagnosis. there is in form a lentiform of the lens shaped of the biconvex है. If you see this in this, it looks like a bioconvex lens है. ठीक है. So यहाँ पर एक लिखा है lentiform. Okay, so lentiform of the lens shaped. Okay, lens shaped in the CT scan. It looks like a lens shaped. It is a gold standard diagnosis will be the CT scan. Okay, so this is all about your extradural hemorrhage. Now subdural hematoma. Okay, so epidural हो गया. ठीक है, that is extradural हो गया. Now come to the subdural hematoma. Okay, so here in this subdural, so there the blood accumulates in between the spaces between the durameter and the arachnoid spaces. Okay, so here the blood accumulates in the durameter and the arachnoid space. ये जो the points है ना, ये सब याद ही रखना. ठीक है, these are only important points. इतने में से ही आएगा. ठीक है, between the durameter and the arachnoid space. Okay, so there is a disruption of this cortical vessels. Okay, and in the what to say, so here will be the impaired conscious, the patient present with an impaired conscious level at the time of the injury, and then further deterioration. Here the hematoma enters into the brain cells, slowly expanding the venous blood. The subdural hematoma is slowly expanding the venous blood, most commonly in the dura and the arachnoid matter. So there the clinically are conscious level impaired. Impaired conscious level. So this is basically the acute type. Okay, this is basically the acute type. वहाँ क्या था, एक convex lens था, lentiform lens shaped, और यहाँ पर जो lens होगा in the CT scan, it looks like a concave appearance है. So इतना ही याद रखना, it looks like a concave appearance है in the CT scan. Okay. Also, your mortality rate is subdural hematoma is much more higher than that of the extradural hemorrhage. Okay? So this is important. Mortality rate of the SDH is more than that of the extradural hemorrhage. Okay? Yeah. So now come to the next part about your anterior or the skull base fracture. So skull base fracture is divided into two types. One is your anterior cranial fossa fracture and other is your middle cranial fossa fracture. ये difference याद रखो and nothing और कुछ याद रखने की जरूरत नहीं है. Okay. So common site is the frontal bone, ethmoid bone or the stribiform plate. Here it is temporal bone, teres temporal bone. Okay. Most common cause will be the frontal impact injury. This is temporal bone, so lateral head injury. Raccoon eyes. Okay, there is a bluish discoloration of the eyes, around the eyes. Okay, so periorbital ecchymosis and the battle sign, mastoid sign. Okay, here there is you will see there is a bluish discoloration in the mastoid bone. Okay, so battle sign is positive is middle cranial fossa fracture and the raccoon in the anterior cranial fossa fracture. CSF leak via the nose, it is via the ear. Nerve involvement, olfactory nerve, so there is an insomnia. Facial palsy is there and the hearing loss due to the affection of the vestibulocochlear nerve. Associated injury, cerebriform palate fractures, temporal bone fractures. Bleeding time, always there is an orbital bleeding, subconjunctival hemorrhage. Here it is bleeding from the ear. Okay. Complication, insomnia, CSF rhinorrhea, facial nerve palsy, and the sensorineural hearing loss. Okay. Sign of examination: clear watery nasal discharge on bending forward, bloody otorrhea or CSF from the ear. Okay. And most common fracture of the classical triad will be your hematotympanium, CSF otorrhea, and the hearing loss. Okay. So ये आप लोग लिख लो. Battle sign, your which nerve is affected, where you find the recognize. ये सब it is only this questions can and it is included in everything. Okay, so just click it or write it down. Before this, let's move to the brain abscess. So now suppose a person is suffering from the sinus infections. Okay, repeated sinus infection, sinusitis, okay, endocarditis or respiratory infection, anything. Okay, now or he is suffering from otitis media, okay, ear infections, or he is suffering from some dental infections, okay, dental infections, okay, he is suffering from some like any type of the paranasal sinusitis, okay, paranasal sinusitis. So the bacteria from here can enters into the brain, okay, and most commonly they locate in the temporal lobe. Most common they locate in the other lobe also, but they most commonly in the temporal lobe. Then the cerebellum, उसके बाद frontal lobe and the parietal lobe. Usually seen in those patients who are suffering from diabetes or immunocompromised patients, because they are usually suffer from repeated this type of the infections. Okay, so they may be presenting with the focal seizure. Okay, focal sign. Suppose the clinical feature will be a small seizures, eye twitching or twitching of the muscles of the the face. The seizure is the local twitching is there, the local sign. Okay, the local twitching, and they're raised in the intracranial pressure. Okay, and CT scan maybe shows a ring enhancing mass lesion. Okay, so ring enhancing mass lesion. So this is from this you can confirm that the person who has repeated dental problem, and if he is doing repeated dental treatment also, and if there is a bacterial infection, it can easily spread into the brain. Okay, the most common cause of feature now they do the root canal treatment. Okay, in the root canal treatment, what happened? The dead tooth is always stay behind the mouth only, and if anything dead means no oxygenation, there is an overgrown of the bacteria. Okay, but still it is going in a rampant. But yeah, it can be result to the brain access also, but it is basically the bacteria are there, so inflammation in other part of the body may be possible. Okay. So now come to the next part about your normal pressure hydrocephalus. Okay, so this is your normal brain, and if you see there is a cerebrospinal fluid accumulate within the brain ventricle, but the CSF does not do but the CSF pressure does not increases. So that is why normal pressure hydrocephalus. Why it does not increases? Because there is a very slow accumulation of the CSF. The brain adapt usually they stretches themselves and accumulates the extra fluid. As a result, there is a no rise of the intracranial pressure. Okay, so Hakim's triad. This is a MCQ, one of the most important questions. Gait disturbance, earliest and the most common, urinary incontinence, and the cognitive decline. Okay, so these three together is known as your Hakim's triad or the clinical triad for the normal pressure hydrocephalus. CT scan will be shows your enlarged ventricles, but with no increase of the intracranial pressure. Okay? So this is all about your cerebrovascular diseases. ठीक है? ये कितना बचा है? So it is about your 11. Now, this Glasgow scale. This is another important. I think it has come इस बार आया था ये वाला. So it is usually to assess the level of the consciousness of the patient with head injury, okay, or the altered mental status. Score range from 3 to 15. So it is important to consist of three things: eye opening, verbal responses, and the motor responses. Eye opening score will be 1 to 4, verbal responses 1 to 5, and the motor responses, the EVM. Okay? So mnemonic will be EVM. So what you will see, if the eye opening, if it is spontaneous, अपने आप खुल रहा है, कुछ नहीं बताने से, the 4. If it is, if you are telling him, if you're shouting, okay, if you're shouting and in the loud voice, and then the person is opening his eyes, then the number will be 3. Okay? If the person is in pain, if you pinch something, the person in his pain, then his eyes are open, the number is 2. Okay? If there is a no response even after doing all these things, then the number will be 1. So इस तरह से eye opening, verbal response, and the motor responses. Okay? Maximum score is 15, and the minimum score is your minimum score is 3. Okay? So the person who has a score of 3 to 4, that means the patient has a more chance of dying or the remaining vegetative space. Okay? Chance of dying is more, or the person will remain in a vegetative state. Okay? So these are the important things. Okay? So this one, the previous slide, Dr. Saroj, ये हो गया आपका. Okay, चलो. Next, move to the next part of risk factor for the oral cavity. फटाफट finish करते हैं. Okay. So oral cancer risk. Age, ज़्यादा age होगा, chances बढ़ जाएंगे. Okay. So about your ethnicity, Asians and Africans, socioeconomic status, poor has more chance to develop oral cancers. Smoking, too much alcohol consumption, lifestyle, the person who is taking bittel, gutka, pan, masala, वो सब, ठीक है? Any human papilloma virus, person is an immunocompromised. ठीक है? Inconsistent or the limited or no evidence for causing oral cancer, family risk, cannabis use, okay, I don't know what is CART, HIV infections, alcohol in the mouthwashes. These are the no evidence, but yeah, these are the 3 evidence, that is tobacco, alcohol, your betel nut, okay. If there is an ill-fitting dentures, okay, other is your ill-fitting dentures also. Ill-fitting dentures when there is a repeated trauma, okay, so that is another thing. So these are the risk factor for the oral cavity cancer. So most common oral cavity in the tongue is most common than that of the lip. Most common type of the cancer in India is carcinoma of the oral cavity. Most common histological type of CA of the oral cavity is squamous cell carcinoma. Lymph node metastasis is more common in the carcinoma of the tongue. Okay, so these are important thing. And minimum risk of lymph node metastasis is a carcinoma of the lip than that of the carcinoma of the palate, more than that of the carcinoma of the palate. Okay, so lymph node metastasis is more common, minimum risk, okay, the minimum risk actually. So, so let's go to the, what do you mean by the oral mucosal fibrosis? So what happened here in the oral mucosal fibrosis, there is a formation of the bands, okay. तो fibrous band, formation of the fibrous band beneath the oral mucosa, which causes restriction of the opening of the mouth. Okay, restriction of the opening of the mouth because of the formation of the fibrous band. Usually, Asian person who has an history of the betel nut, okay, that's in tobacco, gutka, okay, all these things. Only smoking alone is not associated. It is always associated with some chewing, tobacco chewing, pan masala, okay, with or without use of the alcohol. So there is a fibrosis. As a result, trismus is there. The patient cannot open his mouth properly. There is a burning sensation whenever he eats some spicy food and a warm food. Okay, blanching of the oral mucosa. There is a white lacy layer in the cheeks. This is blanching oral mucosa. Dry mouth because salivary secretion become lesser. Okay, and later stage when then there is a more inflammation, there is a difficulty in swallowing. This is oral submucosal fibrosis. So if a patient, this is very common, and you need to tell the patient to stop this betel nut and whatever the gutka, whatever is sitting. I have seen the patient taking the treatment and continuing this and they resulting into this in the later stage the fibrosis increases and the patient will complain of difficulty in swelling also. Okay, that, and it's a pre-cancerous stage actually. Okay, so it isn't pre-cancerous. Restricted mouth opening due to the fibrous band formation. Scar produced contracture because its contracture is there. Okay, now come to the next part of the carcinoma of the lip. Okay, so most common site of the carcinoma of the lip is in the vermilion of the lip. Okay, vermilion of the lip, and 40 to 70 years. Most common presentation will be the non-healing ulcer. Non-healing ulcer and CA lip has the best prognosis. Lymph metastasis occur, but it is rare, and most common lymph node will be your submental and the submandibular group of lymph node. Submental and the submandibular group of lymph node. Okay, so this is about your carcinoma of the lip. Now carcinoma of the tongue. This is mostly in the lateral border. Okay, the most common in the middle of the lateral border. Okay, so lateral border of the tongue is most commonly affected. Most common type will be the squamous cell carcinoma. The most common type is squamous cell carcinoma. Okay, risk factor are the same than the tobacco and the alcohol. Okay, and the most common variety will be the ulcerative. Okay, so there is an ulcerative variety. Ulcerative variety is the most common type, and 30% of the cases there is a lymph node enlargement, basically cervical node metastasis. Cervical node, not the submental or submandibular, cervical node metastasis. See, operation what done for the carcinoma of the tongue is known as a commando operation. Okay. Combined mandibulectomy with the neck dissection operation. Okay, usually in the first degree of malignancy of the tongue. Okay, so total removal of the tongue also, and also hemimandibulectomy along with the dissection of the cervical node. So this is very what to say, high risk procedure, complicated operations. This is known as a commando operation. पूछा जा सकता है commando operation consists of what the like surgery. So combined mandibulectomy and the neck dissection operation. ठीक है? Yeah. Now come to the carcinoma of the buccal mucosa. So this is carcinoma of the oral cavity. Usually the cause will be the same, the tobacco, betel nut, okay, Arcia, Aracia, nut root or lime shell, चूना, ठीक है, चूना खाते हैं, that is. Now suppose if the patient is taking all this thing and he is developed, whether it is fibrosis and whether it is thing, I use this type of this remedy is more common. One is your arsenic, it has poisoning. Other one is in causticum. Okay, maybe in the latter the Staphysagra also. These are the three important remedies जो maximum use होता है. जरूरी नहीं है हर समय use हो, but maximum cases if you see the causation is there because tobacco, and might be you can also like somehow give relief to them with the help of the lycopodium also because it has the tobacco content. Okay, if you see Allen's Materia Medica, the person who is a smoker. Okay, so even the tabacum also, but most commonly in the arsenic, causticum and the Staphysagra. Chalo. So yeah, and this is low grade squamous cell carcinoma. Low grade squamous cell carcinoma. Okay, so along with this, it is in precancerous stage. It's cancerous, usually the associated with the leukoplakia. Associated with the leukoplakia. Okay. So malignancy of the paranasal sinuses. The most common is the maxillary one. Okay. So this is most common. So I'm writing it here. This is most common, the maxillary sinuses. Then this is second most. Ethmoid sinus get affected. So malignant neoplasm of the paranasal sinus, most common which sinus is affected, maxillary, then the ethmoid, and then the frontal. Okay, so this is in the third number in the frontal, and then the sphenoid one. This is in the fourth. So first, your M, E, F, and then S. Okay. Usually, the person who is working in a hardwood furniture factories. Causative factor, the person who is working in a hardwood furniture factory, okay, or in a leather work. Nickel industries, or the manufacture of the mustard gases. Okay. Most of the carcinoma, the type of squamous cell carcinoma. Okay. Now, depend upon the which sinus is affected. Okay, it causes. Suppose if nasal sinus is affected, suppose if there is a tumor in the maxillary sinus, the patient may complain of what? Nose blockage. Okay, so blockage of the nose, or sometimes there is a blood stained discharge. Blood stained discharge. Tumor which causes pressure in the nerve, so there is a pain, the trigeminal neuralgia, or epi and the facial paraesthesia, or the numbness of the faces. Like I'm writing it in another color. So this is your facial paraesthesia. Okay, so paranasal sinus, that is your malignant neoplasm of the paranasal sinus. Most common is maxillary, then the ethmoid, then the frontal, then the sinus. MEFS. Most common is a squamous cell carcinoma. Usually in those people who are working in a hardwood furniture factories, leather work, nickel, and the mustard gas. Now, if there is an obstruction or the tumor in the maxillary sinus, the patient may complain of nasal stiffness, blood-stained discharges, there is an pain, and the facial paresthesia. Okay, okay, and the lymph nodal metastasis is uncommon. If it is there, the most common for the nodal, they usually spread to the mandibular nodes. Okay, mandibular nodes. Similarly, if it is in the ethmoid, they usually spread from the jugulodigastric nodes. Okay, they usually spread from the which nodes? Jugulodigastric lymph node. So ये कुछ questions they can ask you. Okay, and obviously systematic metastasis is rare. If systematic metastasis is present in the maxillary sinus, the most common organ is your liver. It is very rare, but it is, sorry, liver, it's lungs. Okay, so this is your the lungs. CT scan, how will you diagnose this case? With the help of the CT scan. It is non-invasive and we can get the extent of the tumor also. The CT scan is the most common investigation of the choices. Okay, so this is all about your carcinoma of the paranasal sinuses. Let's wait for 2 minutes. Now come to the salivary gland tumor. Now, the salivary gland tumor, they are divided into the benign and the malignant. Among the benign, the most common is your parotid gland tumor, followed by the submandibular gland, followed by the sublingual and the minor salivary gland tumor. Okay? So basically, salivary gland tumor is also by the major and the minor. Okay? So salivary, most common minor, if it is in the minor salivary gland, okay, so most common site of the minor salivary gland tumor is in the hard palate. And oral cavity, especially in the hard palate. Now, this is, I'm saying about your pleomorphic adenoma. Pleomorphic adenoma. So this is most common benign tumor of the salivary gland. So what is the most common benign tumor of the salivary gland? The answer is your pleomorphic adenoma. It is a benign mixed tumor, most common benign salivary gland tumor. Okay. Why it is called mixed? Because it consists of both the epithelial and the mesangial elements. Okay. Most common site of this parotid pleomorphic adenoma, most common site is in the parotid tail. Pleomorphic adenoma, it is also seen in the submandibular gland. It is also seen in the submandibular gland, but in rare, and also in the sublingual gland, but most commonly in the which gland? In the parotid gland. Okay. They usually, pleomorphic adenoma, they do not involve the facial nerve. They do not involve facial nerve. Okay. So parotid gland, superficial lobe, and minor cerebellary gland में palate, lips, and the buccal mucosa, the soft palate. Okay. Now, what are the clinical features? Slow growing, painless mass, mobile mass, usually seen in the middle-aged females. Female are more common affecting than that of the male, around the 40 years. If it is very large, it may distort the face. If it is very large, if you see, it will distort the face. Okay. Facial nerve palsy is rare. If facial nerve is affected, if facial nerve is not affected, pleomorphic adenoma, if it is there, that means it is a malignancy. Okay. And the IO investigation of the choice will be of the FNSE. Okay. So sometimes this is also called as a dumbbelled tumor. So it looks like a dumbbell. So pleomorphic adenoma, it is also called as a dumbbelled tumor. So if it is involved the deep lobe and may pushes the tonsils also, okay, it is known as a dumbbelled tumor. So other clinical feature pathology, if it is well circumscribed and often with pseudopod-like extension in the surrounding tissues. Okay, so it looks like a pseudopod extension. Okay, looks like this type in the MRI. High recurrence if not removed with the margins. Okay, so these are the important feature of pleomorphic adenoma. Malignancy changes are rare. It occurs only in 3 to 5% of the cases. How will you know? If there is a rapid growth, achanak se rapid growth, and also it with pain, and the facial nerve palsy is there. If facial nerve palsy is there, facial weakness is there, and rapid growth, then think it is a case of your parotid gland carcinoma. Now come to the Warthin's tumor. It is adenolymphoma, exclusively seen in the parotid, the benign tumor. See, the pleomorphic adenoma can be seen in the other salivary gland, okay, but this Warthin's tumor, it is basically exclusively seen in the parotid. Okay, it is a benign salivary gland tumor. It contains cystic spaces, papillary projections, and the lymphoid tissues. Contains strongly associated with the smokers. Okay, so ये important. Sometimes they can ask which tumor is exclusively seen in the parotid gland. Your answer will be your Warthin's tumor. FNAC is the best diagnostic procedure. Okay. So it is a plain, a painless, slow growing mass, soft, can be bilateral, okay, or multicentric. There is no malignant transformation. It is usually rare, usually benign throughout the life. Okay. Now mucoepidermoid carcinoma. This is the most common radiation-induced neoplasm of the parotid. Yes, sir. Okay. What is the most common radiation-induced neoplasm of the parotid? Your answer will be your mucoepidermoid carcinoma. Okay. Mucus secreting cell and the epidermal component. 1 minute. So mucus secreting cell and the epidermal component. It is if it is low grade type, it secretes mucus. If it is in high grade, it is epidermal component. Okay, in the low grade, usually occurred in the children, whereas the high grade, there is usually occurred in the adult, and they are poorly differentiated. Okay, so basically the tumor is also harder, and they have more chances to get malignant. Okay, so that is your the adult one. They usually not causes any facial paralysis. This type of the tumor, basically a cancerous tumor of the parotid gland. Now, adenoid cystic carcinoma. Now, this is the second most common malignant tumor. Most common site will be a hard palate, then the sinonasal tract. Peculiarity is there. It is basically perineural invasion, a treacherous type of the tumor. Okay, the tumor will goes like a like an involvement such as of the arteries, like this type. Okay, if you see this, the tumor is like a like this type tumor. Okay, so treacherous tumor. Okay, so most common origin will be in the hard palate. Okay, of the minor in the minor salivary gland, especially in the hard palate, and then in the sinonasal tract. And they affect the facial nerve. So facial nerve palsy is usually there. Most common, they affect the facial nerve. And harvesting system of the long bones are also involved. They may also grow along with the Haversian system of the long bone without any bone destructions. Okay, they have a high incidence of the distance metastasis. High incidence of distant metastasis. Okay, so most common site is in hard palate. So this is all about your adenocarcinoma. Investigation of the choice is FNAC. Most common site of distance metastasis is the lungs. Now, what are the complications of the parodictomy? Okay, the complications are the hemorrhage, injury to the facial nerve paralysis, injury to the mandibular nerve. There may be parotid fistula, and the other is your Fraze syndrome. This is important. Fraze syndrome है क्या? ठीक है? So Fraze syndrome is what? Suppose now, yeah, let it diagram करते हैं तो आपको समझ में आ जाएगा. What is Fraze syndrome? It is basically what happened. Now suppose this is your skin. Okay, I'm just opening my video. Suppose see here where you can. So this is your skin part. Okay, so I'm writing it here that this is your basically this. Okay, and here it is your salivary nucleus. From that salivary nucleus, the nerve which is coming out is your glossopharyngeal nerve. Okay, so glossopharyngeal nerve. 1 minute. So afterwards, it enters into the otic ganglion, and from this otic ganglion, the nerve which is the coming out, and it goes and basically it supplies the parotid gland. Okay, so here this is your suppose the parotid gland. Okay, it's parotid gland, so it supplies the parotid gland. Now there is another sympathetic nerve which has another branches. The branches is your auriculotemporal nerve. Let me show you this one. So this is a sympathetic secretion. So there is another sympathetic secretion from here. The nerve which is coming out, it is known as your auriculotemporal temporal nerve. Now this auriculotemporal nerve, okay, it also basically supply your parotid gland. Now what happened in the parotictomy, the most common nerve which is injured is your auriculotemporal nerve. This is the most important questions. The Frei's syndrome is usually occurred if there is an injury in the auriculotemporal nerve. The Frei's symptoms, what happened? The parotid gland, there's an operation, the parotid gland get operated, and as a result, the most common nerve injured is your auriculotemporal nerve. Okay. So when this nerve get injured, nerve get injured, what happened? Now this glossopharyngeal nerve, when this nerve is injured, this auricular, now suppose I erase this part, okay? So this has been already, it get operated. Now what happened? Now this auriculotemporal nerve will give some branches, okay? Now there is a no parotid gland. Now these branches usually, now they attach to the skin. They attach to the skin, okay? Now whenever the patient or whenever who has an parotictomy, if he see any food, so what happened? The secretion, because it is coming from the sympathetic plexus, the secretion from that area increases. The most of the clinical features will be erythema, okay, erythema, sweating on just seeing the food, okay, on seeing the food. So there is an flushes, basically there is an sweating and erythema over the region of the parotid gland and over the cheek due to the automatic stimulations only just seeing the food. This is mostly due to the injury of the auriculotemporal nerve. So there may be facial flushings, erythema, sweating only on seeing the food. Okay. So if you see this, it's a disorder characterized by the facial flushing, sweating on the area over the parotid gland after the removal of the parotid gland. Okay, so this is a gustatory, also known as a gustatory sweating. Means on just looking the food, there is a sweating which comes out in this area and the area becomes reddish. Okay, this is mainly due to the which nerve? Auriculotemporal nerve, injury of the auriculotemporal nerve. So this is called as a Frei's syndrome. Okay, as an important MCQs. Which nerve क्या होता है, ठीक है? And diagnosis by the minor starch iodine test. ठीक है? Now come to the, what do you mean by the your ciliolithiasis, okay? So basically stone in the salivary gland. Most common gland which is include is a submandibular gland, which is important. Why? Because submandibular gland has a thick alkaline saliva. They have a higher calcium content. The calcium stone is most commonly formed, and long upward duct. There is a pain and swelling of the gland during the meals. Usually the pain increasing after sucking the lemon. Okay. So if the after sucking the lemon, classically by sucking the lemon. This is also known as mealtime syndrome, and the effect is firm and tender. There is a reduced or absent saliva from the duct. So most common gland will be the submandibular gland. Okay. Now this is your ranula or your salivary gland, or this is ranula. In the ranula is a cystic swelling of the floor of the mouth, and it looks like a frog's belly. Okay. It is commonly in the lesions by the local trauma or the duct rupture. Okay. Usually seen in where? In the floor of the mouth. If you see, it is a dome-shaped, fluctuating and the painless, dome-shaped and the painless. The color is usually bluish and slightly reddish, okay? So these are the ranula. We have seen in the Allen's keynote, there are two main medicine for the ranula. One is Thuja and the Ambragracia. I've never used it. I've never got a case of ranula. That's the thing. So Ambragracia. Okay? Now come to the Sjogren syndrome. It is an autonomic disorder characterized by the lymphocytic destruction of the exocrine gland, not the endocrine one, exocrine gland. So salivary gland, mainly the lacrimal gland. Salivary gland में saliva secretion होगा, so there is a dry mouth and the dry eyes. Usually the clinical feature of the Nux mosstata. If you see the clinical feature of the Nux mosstata from your chronic diseases or from the Metromedica Pura, you will be exactly getting the symptoms of the Sjogren syndrome. Okay, so there is a dryness of the mouth and the dryness of the eyes. Okay, there are two types. Primary Sjogren syndrome usually occurs alone. Secondary one is associated with some other autoimmune diseases such as rheumatoid arthritis, SLE, and systemic sclerosis. Okay, now what are the investigation? The investigation will be your schema test, that is tear protection is lesser. Anti-ROSSA and the anti-SSB antibodies are very important. They are usually very high in the early onset and longer the disease duration. Okay. Salivary gland biopsy will show the lymphocytic infiltration and the reduced salivary flow. Okay. And what are the complications? It can cause repeated inflammation, can cause dental caries, corneal ulcers, and the non-Hodgkin B-cell lymphoma. Okay? So these are some of the. Okay? चलो हो गया. Now come to the carotid body tumor. ठीक है. So carotid body tumor में सबसे जो यूज आता है, what is lyricine. Okay, this is very important one. The carotid body tumor, its other name is your chemodectoma. Okay, arises from the chemoreceptor cells. Okay, visually there is an located at the bifurcation of the common carotid artery. They are benign, they are not malignant. Remember, they are the benign. Common in the people who are above 40 years of age. They are the slow going, painless, pulsatile swelling of the tumor. Large tumor may produce some pressure effect. Okay. Large, so they are the benign tumor. So usually seen in the patient who are living in a high altitude, especially who are living in the high altitude or in a in the hilly areas. In the hilly areas, they usually suffer from this carotid body tumors because of the chronic hypoxia. Okay, so usually seen in the 40 years, they have a following history. If you if you auscultate that carotid, you will see a bruit. You will hear a bruit. Okay, a bruit may also present. Okay, and if you do with the carotid angiogram, okay, this sign, it looks like a Leidy sign, that is spline of the internal and the external carotid arteries. Remember, in carotid body tumor, FNAC and biopsy should be contraindicated because they have highly vascular nature. Carotid arteries are there. So that is why FNAC and the biopsy should be contraindicated. Okay, should not be done. ठीक है. So this is carotid body tumor. हो गया. तो important इतना ही है, the Leidy sign. Okay, where you will and FNS and biopsy should be contraindicated. So now, what do you mean by the cystic hygroma? Okay, cystic hygroma present in the neonatal or in the early infancy. Multiple locally aged cystic, which is lined by the endothelial cell. छोड़ दो. It is caused by the sequestration of the. This is a normal one. Okay, so there is a sequestration of the jugular lymphatic lymph sac from the lymphatic system. Okay, so there is a clear fluid in that area, most commonly seen in the person who are suffering from the cystic hygroma, associated most commonly with the Turner syndrome. Okay, and usually seen in the posterior triangle of the neck. So most commonly in the posterior neck region. Okay, others are there such as axilla, mediastinum, but it is rare. But most commonly in the posterior neck mass. Okay, it will usually a soft cystic mass is produced, especially in the infancy, in the early infancy, and sometimes they have a chance to prone to infected. Okay, so infection is there, and how will you? They are the brilliant trans illumination test is positive. Okay, so remember trans illumination test is positive. Okay, it consists of lymphatic fluid. Okay, so trans illumination test is positive. Soft cystic painless swelling. If the lesion become large, depending upon the where the lesion is situated, there is a difficult breathing, swallowing. Okay, rapid enlargement will resulting into the infections or the hemorrhage. Okay, so this is all about your cystic hygroma. Diagnosis by the ultrasound, and the prenatally detected the during the pregnancy. ठीक है, अभी थोड़ा MCQ करते हैं थोड़ा. So can you tell me what is the most common site for the cystic hygroma? And the answer question number 2 and the question number 3 जल्दी से लिखो. So B, good, and the typical multi-located good. So everybody is right. So the answer is B. Chalo. Okay, now come to the brachial fistula or the brachial cyst. ठीक है, इसको थोड़ा समझा देते हैं and we will finish it. Okay, उसके बाद cleft palate आएगा and then it is going to finish most of the this. Now this is अच्छा, इसको basically ऐसे समझते हैं. Now suppose these are the pharyngeal cleft 1 2 3 4 5 है. Okay, first pharyngeal cleft, second, third, fourth, sixth. The fifth one is obliterated. ठीक है, so 1 2 3 4 6. Here it is also. These are the pharyngeal cleft. Okay, this chart 1 2 3 4 and this 6. Okay, and these are the pharyngeal arches. Okay, ठीक है, so this is your and this is your epicardial ridge. Okay, so what is this? This is your epicardial ridge. This is your epicardial ridge. Now what happened here? Basically, from the first laryngeal. Okay, so from the first your cleft, pharyngeal cleft, and then in the second pharyngeal cleft, they joined together. Okay, they join together in the epicardial ridge and form a closed cavity. And there is another closed cavity is produced in second, third, and the fourth and the sixth. Okay, so there is another closed cavity is produced in second, third, fourth, and the sixth. So this is known as your cervical sinus. Okay, so this is called your cervical sinus. So this is called your cervical sinus. So what happened in the brachial cyst? Basically, what happened in the brachial cyst? This now remember this sinus get obliterated. This get obliterated if the age increases. Okay, during the preterm stages, this cervical sinus this get obliterated. Now, if it is present in adult and not get obliterated, then it forms a suppose it is not able to, then it forms as a brachial cyst. Okay, so then it is called as a brachial cyst. So brachial cyst is what? Basically, it is a vestigial remnant of the second brachial cleft. Okay, because it formed on the first and the second, and they formed a closed cavity. If it is not get obliterated, then it is known as your brachial cyst, and the brachial cyst is usually the remnant of the second pharyngeal cleft, or you can say the brachial cleft. Now this contains some fluid. Okay, now this contains some fluid which is full of the cholesterol. Now this contains some fluid which is your full of cholesterol. And this brachial cyst is usually more commonly seen in where? In the basically in the middle upper and the middle third of the sternocleidomastoid muscles. Okay, so basically if it is usually, this is the sternocleidomastoid muscles usually present in the upper neck or in the upper and the middle third of the uh, sternocleidomastoid muscles. Okay, and it is in fluctuant swelling. How will you diagnose this case? By the ultrasonography and the FNAC is the diagnosis. The patient may, it is comes also in the first brachial cleft also, it is also present in the second, like in the first part of the sternocleidomastoid muscles, the second part, on the third part, it can, the swelling, it can be in anywhere. Okay, but most commonly it is in the middle part. Okay, upper third and the middle third of the sternocleidomastoid muscles. Okay, so it usually consists of fluid filled with the cholesterol crystals. So it is usually due to the vestigial remnant of the second brachial cleft. It is if it is not get obliterated. Okay. Now suppose if there is an yeah. Now suppose it doesn't joins into the epicardial ridge. Now suppose if it is doesn't, the first and second cleft doesn't join into the epicardial ridge, then they form a cavity. Okay, now this cavity is known as your branchial cavity. Okay, or the branchial fistula. Okay, now branchial fistula has two openings. This is your external branchial fistula, which has opening into the external side in discharge of the sinuses. Okay, external branchial fistula. Okay, whereas the other one is in the internal type, where the opening is in the internal branchial fistula, and the internal branchial fistula, it is most commonly in the second pharyngeal cleft. Now suppose if there is this opening has been, there is a fistulous formation. So suppose there is an fistulous formation, okay, in this pharyngeal cleft. So there is a cavity which basically, sorry, just using the another pen. So there is a cavity which is formed here in the internal part, and we know that second branchial cleft, what they produced, they produce your tonsillar fossa, palatine tonsil or the supratonsillar fossa. The second opening of this branchial cleft, it is opens into the second that in the tonsillar fossa. Okay, so usually what you will see, there will be some recurrent mucus. In case of internal branchial fistula, there are in the external type, there is some recurrent mucus or mucopurulent mixture coming out from the neck. Okay, usually this type of the branchial fistula, that is the external type, usually they occur into the lower third. So यहाँ पर एक like fistulous opening रहेगी और यहाँ से ही कुछ mucopurulent discharge होगा, usually seen in the external type, where the internal type is usually occurred in the second part. So there is an internal sinus inflammation within the tonsillar fossa. Okay, so there is a formation of the sinus rather than that of the fistula. Okay, so these are the branchial fistula is two type. एक का opening external बाहर की तरफ होता है, दूसरे के भीतर की तरफ, most commonly towards the tonsillar fossa. ठीक है, so these are the clinical features, that is painless, soft fluctuant swelling, located in the lateral aspect of the neck, increased in size during the upper respiratory infections, usually no overlying skin changes, sometimes fistula or sinus may form. Okay, these are the clinical features of the branchial cyst. Okay, chalo, and come to the carcinoma of the larynx. Most commonly is a squamous cell carcinoma, ज़्यादा नहीं है, इतना ही पढ़ो. Men who is age of 50 years, smoking, alcohol, and the occupational exposures. It has three types: glottic, supraglottic, subglottic. Most common is your supraglottic one. It is the glottic one, which affects the true vocal cord. The first clinical feature will be the early hoarseness. Okay. And here rare lymph node spreads naturally initially. Supraglottic, above the vocal cord, most complaint will be the dysphagia and the throat cancer. Okay? Whereas the subglottic is below the vocal cord, which is rare and having the late symptom. The late symptoms will be the hoarseness. Okay? Hoarseness. And the earliest symptom क्या होगा? Earliest symptoms will be the stridor. Okay? So remember this one, the carcinoma of the larynx. So this is about the previous slide, means which one? This one?
No, I'm just trying to see larynx.
CA larynx. Okay. चलो, हो गया?
Yes.
Finish? Okay, so this is the next slide. Now come to the nasopharyngeal carcinoma. ठीक है? So, so nasopharyngeal carcinoma most commonly कहाँ होता है? That is in the China and in the Taiwan, southern east states. Most common tumor to produce the cervical lymph nodes. This is the most common tumor which produce the cervical lymph nodes. Usually, most commonly, what are the risk factors? Burning of the incense or the wood. Okay. Also the salted fish, burning of the salted fish. Okay, or use of preserved salted fish, lack of vitamin C. They are the risk factor for developing the nasopharyngeal carcinoma, and most common the virus will be the epistem B virus. ठीक है, ये Jacob's triad and the Trotter's triad, you should remember this. The Jacob's triad consists of trigeminal neuralgia, amaurosis bulbi, basically blindness, and the ophthalmoplegia. Okay, Trotter's triad, that is trigeminal neuralgia. Okay, that is in trigeminal neuralgia, conductive hearing loss, and the palatal palsy. So this two triad you should remember, to seen in where and what are the triad for this Jacob triad. Okay, so consists of trigeminal neuralgia, amaurosis bulbi, ophthalmoplegia, and Trotter's means T for the trigeminal. Okay, palatal palsy and the conductive hearing loss, especially the nerve which is affected is your 5th and the 10th cranial nerve. Okay, remember, most common site for the origin. Okay, the most common site for the origin for the nasopharyngeal carcinoma is your fossa of Rosenmuller. Okay, so ये एक important है, that is fossa of Rosenmuller. Okay, in the lateral head of the lateral wall of the nasopharynx. ठीक है. So patient may complain with you or cervical lymphadenopathy. So nasopharynx, so there is a blockage of the nose, for nasal speech, epistaxis. Okay, these are the common clinical features. The features of hearing loss is also there, blockage of the Eustachian tube, conductive. Sometimes there is a suppurative otitis media. Okay. Okay. Now, what do you mean by the Pancoast tumor? Okay, so it is a malignant tumor located at the apex of the lung. So where it is located? It is located at the apex of the lung. So this is important. Okay, seen in the male smokers of age 50 to 70 years. Account about 3 to 5% of the clinical features. Now, what is the pathophysiology? Since it arises from the superior pulmonary sulcus, it causes, if it invades the brachial plexus, it causes shoulder, arm, and weakness. If it affects the sympathetic chain, the clinical features of the Horner syndrome, ptosis, meiosis, and hydrosis, very important. The clinical triad of the Horner syndrome. Okay. And the ribs and the vertebra, it causes bone pain. Okay. So basically, clinical features will be shoulder and arm pain, Horner syndrome, muscles weakness and the atrophy if they affect the C8 and T1 nerve, cuff hemoptysis and the weight loss. So these are some of the clinical features of the Pancoast tumor. Investigation, chest X-ray, to know the extent, MRI and the PET scan for the metastasis. ठीक है, चलो तब हो गया. Anybody? मैं next में जाती हूँ and this is the last time. This is finish. Okay, so cleft palate and the cleft lip. तो ये याद रखना. So cleft palate and the cleft lips predominates in the male. ठीक है? Cleft palate alone is more common in the female. Cleft lip and the cleft palate seen in the 45% is more common. Isolated cleft lip is 40%, cleft lip alone is your 50%. That means your typical distribution will be the cleft lip and the cleft palate is about 45. More common is when the cleft lip and the cleft palate together. Usually what happens, abnormality in the fusion of the maxillary and the medial nasal processes causes your cleft lip. So cleft lip is due to the abnormality in the fusion of the maxillary and the medial nasal processes. Okay. So yeah, so if you see this one, failure of the fusion of the, no, this is cleft lip. So basically it is a congenital defect due to the failure of the fusion of the maxillary process with the medial nasal process. It has various type, unilateral. This is unilateral. It consists bilateral also. So यहाँ से भी एक fissure develop होगा. Okay, sometimes it is complete, sometimes it is incomplete. Median are the rare. Split in the upper lip, feeding difficulty, often associated with the cleft palate. Okay, so this is, and the when the cleft lip should be operated. If it is unilateral, it should be operated in the 5 to 6 months, and if it is bilateral, it should be operated at 4 to 5 months. ठीक है? Okay. Now come to the cleft palate. It is a congenital defect due to the failure of the fusion of the palatine shelf. Okay, so this is the palatine shelf. It get diffused normal, but if it do not diffused, okay, if it is still still it is open, okay, then it is called as a cleft palate. So these are the some of the clinical feature of the cleft palate. And the cleft palate, if it is in soft palate, it should be operated at the 6 month, okay, and the hard palate, it should be operated at the 15 to 18 month. Okay. So yeah, this is bilateral cleft lip and the palate, and this is one is unilateral. Okay. So it has written there cleft lip repair 3 to 6 month, cleft palate. Okay. If your 6 to 18 month means unilateral palate को पकड़ के मैंने बोला है hard palate and the soft palate. ठीक है. Basically they have a genetic predisposition of the mother has taken too much steroids or epileptic drug during her pregnancy phase. ठीक है. So this is a so the important होता है कि कब operated किया जाता है. This is one of the MCQ question that they can ask. ठीक है. So anybody किसी का था कुछ प्रीवियस स्लाइड, तो यही है प्रीवियस स्लाइड. चलो. Yeah. So mid-phase fracture divided into the type 1, type 2, type 3. This is also known as a Lee 40 fracture. So Lee 40 fracture means if you see fractures line runs above and the parallel to the palate. ठीक है. It effectively separates the alveolus palate and the facial skeleton. If it is Lee 42, if you say this is your pyramidal in shape, okay, so it is pyramidal in shape. It passes through the root of the nose, okay, and the lacrimal bones also, some part of the floor of the orbit, okay. So an orbital fold is also involved. This is your Lee 42. Now Lee 43 means there is a complete disfigurement, okay. So there is a complete disfigurement of this skull. Okay, so fracture lines run through the nasal bridge. Fracture lines runs through the nasal bridge, through the septum and the ethmoids. Okay, so there is a fully fracture of the whole face basically. So this is your Lee 42. Mid-face fracture involving the axilla can be classified into Lee 41, Lee 42, Lee 43. So Lee 41 में क्या है? That is fracture lines runs above the parallel to that of the palate. ठीक है? And it is pyramidal in shape, involves the orbits also, root of the nose, some part of the and the lacrimal bone, some part of the floor of the orbit. ठीक है? So this is about your Lee 40 fracture. Okay? हाँ, now come to the what do you mean by the triage? ये आता है, and it has shorting the patient according to the severity of their condition, especially in emergency situation and the disaster. So red, immediate; yellow, delayed; green, minor; expectant, dead. Okay. So ठीक है. So this is finish. Next class आपको बता दिया जाएगा कब होगा. ठीक है. So anybody have any questions? तो मैं वाइन कर दूंगी अभी के लिए. So your general surgery somehow finish most of the topic. If anything topic like do let me know in मतलब मुझे WhatsApp भेजो. ठीक है. कुछ टॉपिक रह गया है तो otherwise most of the topic are completed. ठीक. So thank you.